Over to you, Dr.
Good evening to you all. First of all, I would like to thank the College of Palliative Medicine for inviting me to deliver this lecture. And I'm very happy indeed to accept the invitation and to talk about a little bit about our part of work that we can do for the patients you all be handling. So here, I'm talking about what OMF surgeons can do for a palliative patients. As we know, and we are aware that you are all a big team, not like us, and in a patient's terminal stage of life, he needs a lot of help from various areas, and you all are supposed to collectively give that service, and it includes many disciplines, so a lot of interaction with others, and the involvement of a lot of uh, healthcare as well as other social workers and other people. So as what we see, the dental or oral involvement here is not that adequate, or it could be underutilized as what we perceive. So we can understand that as clinical or surgeons, the surgical interventions are not that much appropriate or suitable in these terminal stages. But with some minimal interventions, I think we can do a drastic change for the lives of those patients. Why our care is important here? So we know that the face and oral area are a area where there are a lot of important or the vital things are happening, and for a patient's dignity. And if we think about the face, it's our identity. So even in the terminal stages of our life, or even in the coffin, we like to have our identity, a good face with us to the cemetery. So aims and objectives of our lecture is to identify the key probable problems in terminal ill patients and understand the possible oral and facial complications that would come in the future, and to how to manage those things, and to learn and get a nice insight about how to work collaboratively in a palliative setting with other specialties. So according to some studies, a lot of terminal ill patients are having oral complications. Some of the most common ones are mucositis, xerostomy, and candidiasis like things. And these problems are underassessed and undermanaged in the world context as well. So principles of palliative oral care, what we need to think about is to prioritize the comfort and the comfort of the patient and the maintain the functions. So in avoiding invasive diagnostics or therapeutic measures is advisable here, and the patient's goals and the dignity need to be preserved. Assessment in a palliative care, there are various methods of assessment, and routine oral assessment and the facial assessment by means of our the way we do it routinely will be adequate, but there are some screening tools as well. So, what are the OMF related problems in palliative care patients? As you can see, this patient, I encountered this patient in when I was in Badul about, I think, 4 or 5 years back. And when he came to us, he was having this very aggressive cancer, which has developed like within 4 or 5 months' time to this stage. And that by the time that he came to us, there was nothing that we can do as surgeons or in the way of oncological management, because it has spread like nothing. And he passed away in like about 1 week's time after he came to us. So during that time, we did what we could do for him. But as you all know, I think there was no any palliative, organized palliative structure to support this type of patients. And I don't know. I think by this time also, about 5 years later, I think that still there's no. I'm not that much aware about the circumstances there now, but we know that these oral cancer patients are lot of oral cancer patients are there in our country because the oral cancer is the number one cancer in the males of our country. So a lot of these end stage patients, because they present to us in later stages with advanced one, and so this type of patients are very much prevalent in especially in rural areas. So what are the problems they are having? Pain and sensory problems, either due to our interventions, so due to the cancer itself, they are having a lot of pain problems. It could be like surgery associated or phantom or post-mandibulectomy pain, phantom limb-like pain, or it could be related to dental pains. You know, the dental caries pain, that is pulpitis-like pain. They are very painful, uh, and some minor problems like burning mouth like features also there. Communication and speech. These people find a lot of problems when they are having problems in the orofacial area, when they are communicating with their relatives, friends, because these end stage patients, they like to associate with their uh, people, the community that they lived in. So that when they are having communication problems, that is also going to be a big problem for them. So some prosthesis like this is called speech bulb. This is we usually use for velopharyngeal insufficiency for small children who are having cleft palate deformities as well. But here also in these patients also we can use these things to help in speech. And there are prostheses to maintain the structure and functions of the facial and the oral area. This type of prosthesis is also helpful. And eating and nutrition problem, they have a lot of problems here because they have a lack of oral incompetence. The movement of tongues are impaired and tongue is impaired, and they get fibrosed oral structures. So they're having a lot of problems in eating, and which will lead to nutritional problems as well. This is a picture of trismus, where patient is unable to open the mouth. This could happen due to radiotherapy or the fibrosis or the surgery itself. Uh, so management like exercises. We are not going to do invasive surgeries here. Some exercises, nutrition support, surgical manipulation. Sometimes we tend to take the front teeth out also because you know it can make a hole in the anterior part of the mouth, which facilitate the person to take food in rather than going for NGO or peg feeding. So there are oropentral fistulas, which are uh, most prevalent in the oral cancer patients because this radiotherapy and the surgery itself also can cause this thing. When there's a leakage of the saliva from the oral cavity into the mouth, it tends to cause these non-healing ulcers, which are difficult to manage. But small interventions like under local anesthesia, we can do sometimes for to prevent salivary leakage and close this type of or facial fistulas. Serostomia is or the dry mouth is also a big problem in these patients because due to radiotherapy or due to interventions in the salivary glands or medications that we are using, and in some other conditions like decreased fluid intake or increased fluid loss, this can cause serostomia problem, which will lead to many other problems as well. So there are some syllables we can use. If there's any functional residual salivary tissues remaining, these things are helpful. Otherwise, we need to go for some artificial saliva-like things. Oral mucositis is a very common problem in these patients, especially after chemoradiotherapy. So it's very painful, and the patient is having a lot of discomfort and uh, having trouble in taking food. This is WHO grading of oral mucositis. Chewing and swallowing difficulty is also there. So in these cases, we may tend to modify diet, take OG or NG tube effect, swallow therapy will be helpful in these instances. Facial disfigurement, as I told earlier, we want to keep our face look in an acceptable level, but disfigurement can happen due to various reasons like skin erosion or resection, scars, and which will lead to distress or social withdrawal, and patient may go into depression as well. So there are various means to address this also.
Sorry to disturb, Dr. Buddhika. I think there are a few comments on the chat that it's not very clear. Could you speak a bit louder,
And
maybe?
I'm.
Yeah, now it's okay.
It's clear now.
Yeah, now it's clear. Yes.
So a prosthesis will be helpful in managing this facial disfigurement. Now some few OMF surgeons are interested in making this. So I think as I got to know recently, some went to India also to do some courses to prepare how to learn how to prepare these facial prostheses, and there are ways that we can get these things down if there are patients. Facial muscle dysfunction also could be due to various reasons, fibrosis, tumor erosion, or facial nerve injury. So it can lead to asymmetry, drooling, or eye care issues as well. There are ways to manage that facial, say for example, eye care, we can go for tarsorrhaphy or putting some gold plate into the upper eyelid like procedures. And to make the facial symmetry, there are ways that we can inject some Botox into the other side and paralyze that and make it symmetrical. Drooling of saliva, it also could be due to high salivary flow or the patient's inability to swallow what is normally produced in the mouth, or it could be due to defects in the corners of the mouth or in the lower lip area or non-function, or could be due to defects or non-functioning, which will cause drooling of saliva. So correcting a defect and drug therapies like pyruvate to reduce the salivary flow, and or neuromodulator injection into both parotids and submandibular glands also help in reducing this. Loss of smell and taste. This is also a problem they are facing, and so it will lead to poor appetite and distress. ARV management challenges also there. It could be tumor compression itself or anatomical distortion of the oropharyngeal structures, and can cause breathing difficulties. So these things should be foreseen and need to be managed or planned beforehand before they arise. Oral hygiene and mucosal issues also there, mainly due to xerostomia, dry mouth, and it can induce infections and halitosis like problems, ulcers, bleeding, and it can lead to a lot of dental caries as well. Main oral infections that occur in the terminal stages are like candida, herpes, or bacterial infections. This is a type of dental caries that occurs in the dry mouth, because you can see at the dental caries at margin, which causes breakage of the crown part of the tooth and leaves the roots behind, which will ultimately set into infections, and a lot of problems can occur if the pus drains into tissue spaces and track down into various other parts of the body. So candidiasis. So candida infection is the commonest infection or the fungal infection that occurs in these patients, and It can occur in various forms. Some antifungal protocols are there, and the underlying causative factors like diabetes or the immunocompromised state also need to be corrected in these instances. Halitosis is also a big problem when they're communicating with others. If they're not having that much of a good oral hygiene, this can cause a lot of distress to these patients on top of the agony they are already undergoing. There are a lot of causes for halitosis as well, but the commonest ones are like things that occurs in orofacial area. Psychosocial and functional problems also there. Facial disfigurement and body image disturbances, loss of communication and social isolation, and sleep disturbances and emotional distresses. Prosthetic and reconstructive challenges are there, but to a certain extent, we can get things done here. Then there are, as I told earlier, there are ways that we can get down it from foreign countries to cheaper rate as well. So some treatment-related issues also there. Osteoradionecrosis is a big problem which causes severe jaw pain in patients who have undergone radiotherapy. And even after chemotherapy also this osteonecrosis could occur. And mucositis and infections from chemotherapy also a possibility. It's a part of picture of osteoradionecrosis where we are supposed we can do with the minimal invasive approach some debridement here and the closure of the wound under local anesthesia. Danger related issues also there. They can be loose fitting and can cause ulcers in the mouth. And our prosthodontist colleagues are there to smoothen them to the remedies for those problems. Jaw pain and metastasis, even there's no any primary problem in the oral cavity, there could be jaw pain that could be due to metastasis, and we have seen renal cell carcinomas and prostate cancers tracked into the mandible and causes mets, which need to be vigilant in this patient. So during this palliative care, we have to respect, we understand that we need to respect the cultural values because these people, they are not going to get cured. So they are living the end stage of the life. So what they believe, the religious and cultural beliefs need to be respected and should be allowed. OMF procedures, we can understand we need to avoid major surgical interventions and minor interventions like drainage, debridement, or putting some stitches or giving some oral care will be very much beneficial in these patients. And when we are communicating, we need to be honest that we understand and discuss the possible goals with the patient because though there's no cure, at least comfort we need to provide. Consent, getting a proper consent and caring ethically is utmost important. So caregiver education. We know that as OMF surgeons, when we encounter these patients, the people who are looking after those people, they do not have that much of education in looking after the oral and facial health of these patients, so that the educating them also of very big importance, because I think the palliative team also can understand this. So this is a part of, we are in a multidisciplinary team role. OMF surgeons, dental surgeons, and all other specialties need to be together to make joint decisions. I mean, sequencing the treatments or the care protocols, and to engage and work as a team. In our practice, what we see is though a lot of we have a widespread OMF clinic throughout the facilities throughout the island, and surrounding dental clinics also there, which are helpful in our carrying out our treatment procedures. So in palliative practice also, what we see is these facilities are underutilized, so that it will be better if you pay a little bit attention on this aspect as well, because these facilities are available, and if you think of using it, it will be beneficial for the patients. Uh, Training the staff for oral protocols, identifying problems is necessary, and documentation. There are low-cost oral care kits that can be obtained easily at a cheaper rate, and will make a big change in the patient's oral patient health. OMF referral, it could be done throughout the country. It's available. So major centers up to district general hospitals, the OMF units are there now. So you can anytime contact them and get the incorporation into the palliative work. So as a takeaway, orofacial care is, we think, essential to maintain good quality life or end stage life. And even simple interventions can make big impact. And if the team can be organized properly, then it will be very much helpful for the people who are suffering.